what do we know about the point of care diagnostics that are available for COVID-19? And are they sufficiently accurate? Is there a range between different products, things like that?
Yeah, so that has been one of the biggest struggles of this pandemic. There's been a lot of variability in test performance, and even in the tests that do work pretty well, it's been challenging to scale it up because of the massive need that I think uh, most people did not really anticipate. Um, Although there has been a lot of headway during the past 2 or 3 weeks or past couple months, even uh, there is still a lot of work that needs to be done, and it depends on the assay. The sensitivity can be between 80 or 90%, and on a using like a good assay. And while that might sound good, if you have a person that seems to fit the disease that you would think, and has a negative test, 1 or 2 out of 10 people having the wrong result, that could eventually infect other people. Yeah, I think there still has to be a lot of clinical interpretation of what we call like the pre-test probability or the clinical probability that someone might have an infection, and then you have to add in the like a very good understanding of the test that you're using. So it has.
Thanks for talking about those point of care diagnostics. Now, there's all sorts of other concerns for essential healthcare workers right now as well about PPE, about the economic turmoil, access to childcare, to name just a few. What have you observed in terms of the impact of this pandemic on your colleagues' health and safety, both mentally and physically?
Yeah, I mean, I think there's a lot to talk about there. And I think it is important to remember that um, we're still humans, so we're also going through a lot of the same feelings that everyone else is. Um, the I think the to start with, I think the mental health components are really important. There's I think there's appropriately going to be anxiety about maybe getting infected themselves, but I would say even among the colleagues I've spoken with, even more of a worry about infecting their loved ones. I think there's just the I think the horrible image that we've all thought about bringing home something and then either having a kid or a spouse or yeah, a parent contracting disease from your interaction with them. And I think we have it so uh, ingrained in us that we want to first do no harm. And so I think that that's one of the major stressors. I think from like a daily standpoint, you mentioned childcare. I think that's another challenge. So even people that are able to telework and use like something like Zoom or FaceTime for seeing patients during their normal clinic hours, I think they're still having to juggle not having childcare, and if you have 2 infants at home, I think that's a lot, and especially if you have 2 working parents that also have to do also have to work from home. I think there's no guidebook for how to work with those scenarios. And then I think the PPE one is obviously a safety issue. And I think it varies depending on the hospital. I think some hospitals are more prepared than others, but of course, yeah, personal protection is, I think, certainly a important thing for people to um, that is on everyone's mind. I mean, my feeling is that one of the most important parts is you don't want to get infected and then infect all of your patients. So, I mean, someone that is in their 20s or 30s, they can get sick, or even in their 40s, but perhaps from like a healthcare worker standpoint. But perhaps the one of the biggest concerns is a asymptomatic shedding of a healthcare worker taking care of patients with comorbidities and making sure that you're not a vector, because the last thing someone wants to be is worsening the outbreak rather than treating it.
That makes a lot of sense, and I'm sure that's a really complicated mental thing to juggle, especially in terms of the possibility of bringing it home to loved ones, but also the duty that a lot of people probably feel to be in it right now. And then, I mean, even just in parallel to what you were saying earlier about trainees who can't get involved right now, who are just watching this happen. I mean, healthcare workers who can't be part of the healthcare labor force because they have too many child obligations. I mean, that's the same kind of strain, really. And so
Mm-hmm.
that really makes sense. So the next thing I'd like to ask about is just in terms of pandemic preparedness, what can we hopefully learn from this experience with COVID-19? I know there were a lot of people in infectious diseases who, before this happened, were already saying it's not a matter of if, it's a matter of when.
Mm-hmm. Yeah.
And so now that we know for certain that that was true, and probably will remain true for the foreseeable future. I mean, human beings we're biological creatures, and like any other, and we catch viruses. So what can we do to be prepared for the next time?
Yeah, I mean, I think from like a high level, this is an issue as being biological organisms. We are or biological people. We are limited by some of our evolutionary machinery, and in that we often think emotionally rather than pragmatically. So I think the issue is that we often don't prepare for outbreaks as much as we very robustly respond to them. So I think I think hopefully there is a shift, and I do think there will be a shift in this horrible awakening that we do need to put more resources into preparing and prevention and surveillance, and thinking of new ways to detect emergence of disease, and when those diseases emerge, how to more rapidly and robustly respond. I think we go through cycles of having an outbreak, there being a lot of attention to that, a couple years pass, and then funding goes away for emerging infectious diseases, and then that cycle just repeats when there's another outbreak. So I'm hoping that now that the majority of clinicians and researchers and policymakers and leadership on so many levels are now so affected by this that that this will be something that we can grow from and prevent future pandemics. But it is a major challenge because I think that in the past we have had a hard time sustaining prevention and putting infrastructure into a response until it's been too late. But this is the current situation that we're having is again unprecedented in most of our lifetimes, and I'm hopeful that we'll be able to use this sense of unity that we have right now to both combat the virus currently, but also to think of ways to sustainably try to counteract or prevent this from happening again.
I was wondering, while you were talking, it made me think, is there a relationship between the way we can be forgetful about emerging viruses and the way other diseases are treated as sort of inherently endemic to certain regions, or the way so much in terms of, say, healthcare capacity in a crisis? I mean, does stuff that we kind of consider background disease play a role in that as well?
So do you mean thinking about low circulating viruses that present a emergence risk?
More in the sense of when you look at kind of long-standing health burdens, if there's a relationship between something, not in a direct way, but in a more abstract way, between, like, on the social level, between something like, how many people die of tuberculosis a year, and those kind of slow burn health crises and the more immediate ones.
Oh, yeah. Okay, thanks. Yeah, so I think that's similar to I think the whole people reacting to crisis, but not being passionate about things that are actually a major issue, like tuberculosis. Every year, tuberculosis is a major killer, but I think kind of like I think you maybe have been alluding to, is that there's not a lot of resources or emphasis into either research or care for tuberculosis. But I think there's a lot of corollary benefits to caring for or researching tuberculosis. I think there's a lot of infrastructure needs worldwide, but also domestically to build up that public health infrastructure. So I think if you have more robust surveillance systems, more robust healthcare infrastructures, there's going to be a lot more flexibility for when outbreaks occur. I think there are a lot of great things about the U.S. healthcare system that is unparalleled in other places, but hospitals in a lot of these cities that are getting hit really hard were already very stretched to the limit. So I think when this hit, the already limited resources were just strained past capacity. So I think having it's hard to predict the future, and you can't predict everything. You can't predict every type of emerging infectious disease. And I mean, you honestly could not have predicted what's currently going on to this extent. I mean, there's certain things that you could have thought about. People were saying, and will continue to say, because it's true, that an influenza pandemic like that of 1918 could occur. I think that's what this is most similar to. But there's a lot of things about this that are different than influenza. I mean, this initiated from a zoonotic transmission. This is kind of in a gray area between either people being mildly symptomatic or asymptomatic in some, but then other populations having severe illness. So you have disease propagation that I think may have not been considered in a lot of these emerging infectious disease models, where you're thinking more like viral hemorrhagic fever, where there's a lot more identification. Here, it's very it's really pervasive and hard to detect. So you can't predict everything, but I think building public health infrastructures can provide a little bit more of that foundation, so that we are not already stretched thin in the future.
Absolutely. I mean, we were talking about Ebola earlier, and that is such an issue when we're talking about Ebola, because the current, or hopefully on track to end now, Ebola outbreak in the Democratic Republic of the Congo. I mean, part of the international response to that has been trying to shore up the healthcare infrastructure there, which has already been strained by measles, malnutrition, things of that nature. And so, when an Ebola outbreak happens in Kivu, that's on top of that, all of that. And so, and the ability to respond to that crisis is informed by, of course, the the sort of thing you were just talking about, which is that existing healthcare capacity. So I appreciate that answer. I just, the last thing I want to get to really is, we started out talking about how much this has become a fixation and a something we're all, whether we're journalists or clinicians, we're all following pretty closely. But eventually, things are going to wind down. That doesn't mean necessarily they go back to normal, but things are going to slow in terms, and the rest of medical science, research, treatment is going to have to start up again. I mean, in terms of clinical trials, even things like that. And so I was just wondering sort of what a couple of your other research interests are, and in a sense, what are you looking forward to getting back to when we, obviously the priority here is get through this crisis, right? But when we do.
Yeah, and I think there's a lot of research needs. So I think there's, I think I could create a very long list. But one thing that I'm passionate about is, and this was something that I was passionate about even before the pandemic, but I think it's been even more relevant, is improving our ability to inform clinical decision making, to detect emerging viruses, both using information from the host, so looking at clinical changes and immune responses, but then adding in the diagnostic information, because I think we need more of a comprehensive approach to not only identification of disease, but also stratification of treatment. I think our sepsis models are, I think they've really improved mortality, but there's been a little bit of plateauing where we have had a little bit of difficulty using algorithms to affect sepsis care. And in situations like this, with Ebola or with coronavirus, the pathophysiology does not fit neatly into ways that we treat sepsis for something like community-acquired pneumonia. So I think finding new ways to identify different sepsis pathways that could be from emerging infectious diseases could hopefully improve the outcomes, because sepsis from these diseases does not neatly fit into a one-size-fits-all package. So I think I'm hoping that we can quickly find ways like using host biomarkers to detect patients that may benefit from something that I've been passionate about, and that is immunomodulatory therapy. But I think that's only really become a pervasive consideration now during this pandemic. And I think we need to continue to think about how we can identify people that may benefit from augmenting or preventing collateral damage, depending on where people are in their disease trajectory. I think specific to coronavirus, there's still a ton of questions that need to be answered. I think there's we need to understand more about viral shedding, both in outpatients in the community, but also just while we are picking up virus in different specimens like sputum or respiratory specimens or stool. I think there's still a lot of questions about who needs to be quarantined or isolated, and how infective someone is at a certain stage. And I think incorporating that information again with the way that the individualized care of the patient and the immune response of the patient, I think really could leverage this interest in precision or personalized medicine towards affecting in a positive way the care of patients with these emerging infectious diseases.
Thanks so much for all of your thoughtful answers and your you and your colleagues, the work you're doing right now. It's appreciated.
It's our honor.
Thanks.